Up to date now, here we are, 2018.
Yes.
What do these folks have to look forward to? Is the mortality rate the same as all comers? Is it slightly higher than all comers?
If you look at some of the studies, and they track this better in Europe than we do in the United States, with a lot of things. And in the UK, it's almost approaching normal, healthy males, slightly behind. Obviously, if you have a complication like inhibitors, and I know we'll talk a little bit more about that, your mortality rate could be as high as 2 to 3 times higher.
Okay.
But what we're seeing is it's more morbidity issues than mortality. And so, but certainly in most types of von Willebrand's and hemophilia without inhibitors, those patients are often living almost normal lives.
All right, well, let's talk about the risks and the complications then. What is it about these diseases that affects the population and affects their anticipated lifespan?
The main thing that I see is that people have problems with their joints. People with hemophilia, they get blood pooling into their joints when they have a bleed, and it just compounds over time. So they have joint arthropathy, and they have problems with chronic pain, and even muscle atrophy, because if they have a muscle bleed, that causes problems in the future. And it's also known that they have a higher risk of osteoporosis. So this must have something to do with, the interaction factor VIII with the bone. So we could recommend like extra calcium and vitamin D supplements for them. And for some reason, they have a higher risk of heart disease in one of the studies that I was reading. So it's just another recommendation that we can tell our patients to eat healthy, exercise, and try to decrease their risk.
It's funny how many diseases from how many different specialties. The recommendations
back.
always funnel down to eat better, stop smoking, don't drink too much.
Yes.
And you think that it's generic, but it's not.
Yes.
This is how the body works, Ben.
Sure.
By the way, it occurs to me that the progressive joint disease, I'll bet that it's an inflammatory response. Blood does not belong in a joint space.
You're correct. So as soon as, before we were trying to prevent too many joint bleeds, and now we're trying to limit the number of joint bleeds, because once you set that into motion, it leads to all these downstream inflammatory effects, and that joint is never the same, even one bleed. And they started doing prophylaxis in the 1950s in Sweden and other countries in Europe, and they follow those same men for 30, 40 years, and what they're seeing is we're delaying joint disease into the 30s and 40s, but it doesn't stop it completely, but hopefully we can delay it until much later in life.
If you get down to 0 bleeds, period,
Yes.
the guess would be 0 joint disease, yeah?
Yeah.
Right, so that's the gold standard. That's the goal.
Yeah, and we know that there are some of these what we call microscopic or microbleeds. That's a newer topic that we discuss. And so if you follow their joint range of motion of normal individuals compared to hemophiliacs, even in those milder patients that report I've never had a joint bleed, the range of motion in their joints goes down faster than a normal person. So yeah.
Yeah, the most important probably person at our hemophilia treatment center, and our hematologists agree with this statement, is our physical therapist.
Definitely.
They're really are, they kind of guide a lot of the therapy that takes place at our center.
That whole concept of microbleeds I hadn't heard before, but it sure makes sense.
Yeah.
A little bit here, a little bit there, and it adds up.
Yeah, it adds up. It might not be noticeable, but over time, if you do an MRI, you see these little ditzels in there and cysts that are probably from an old joint bleed.
Well, let's go over diagnosis then, because if it is, I know that the correct term is not variable penetrance, but variable
Expression, maybe.
There's the word. You studied it.
Yeah.
That's cool, didn't you? Sometimes diagnosing this isn't necessarily straightforward, or and not even early in life. So what are the signs and symptoms you look for?
Yeah.
And then how do you work it up?
So like Lacey said before, they often can present with life-threatening bleeding events. Obviously, the more severe, the more likely you're going to present earlier in life. But people need to remember those with mild disease may present into their 10, 15 years of age. I saw a patient that developed it after a tonsillectomy. Everybody thought it's impossible for him to have mild hemophilia, but it isn't impossible. And typical symptoms are oral bleeding, cuts in the skin that take more than 15 to 20 minutes to stop bleeding, a nosebleed that goes on for more than 15 to 30 minutes. And it's difficult because we're not circumcising every child at birth, and so that was a typical event that would lead to bleeding. But 20 to 30% of hemophiliacs won't bleed during a circumcision, and so people get sort of lulled into complacency. But typically it's oral bleeding, nasal bleeds, or even life-threatening bleeding events after a bad delivery.
And how do you work this up? Somebody presents with what looks like abnormal bleeding. What test do you order?
So the typical tests that we start off with are things like PT and PTT. When we're thinking about hemophilia A and B, the part of the pathway would be the PTT test. And so that typically would be prolonged, but usually the factor level has to be below 30% before you really trigger a prolongation of the PTT.
Okay.
And so that's a good start. If there's any concern, if somebody has a circumcision bleed, I typically would send factor 8, factor 9, and a PTT. Because I know if it's prolonged, we don't want to have to go back and stick a hemophiliac one more time to make a diagnosis.
Do you see toddlers with kind of bruising coming in when they're starting to walk? And
Sure. Yeah, exactly. Yeah, so we get these symptoms, and it's obviously depends on the mother's level of concern. Some kids come in and they have one bruise, and they probably don't have a bleeding disorder. And then some kids come in with little horns on their heads from so many hematomas, and that they obviously have some bleeding disorder. We have to remember in von Willebrand disease, the PTT is not an appropriate screening test because the factor VIII level is often normal in the vast majority of them. And so you have to send those specific tests, von Willebrand factor antigen. There are two different functional assays, the GP1B or the ristocetin, and then of course the factor VIII.
Well, if you say, by the way, what I learned is that it's not just one single mutation. This is a raft of mutations and variable expression. If they're having microbleeds, which may not be symptomatic, you don't want them to have that either, and yet they're not going to come to your attention until they're symptomatic.
Sure.
Why not take every live birth, male and female, in the United States and screen them? What's wrong with that?
Yeah, so we actually, it's interesting you said that. When I was a fellow in Pittsburgh, that was actually an idea that we had. We said, well, how much will that cost? Is that a feasible option? And it wasn't, unless the test gets a lot cheaper. Because the problem is that intron 22 inversion is the most common and severe. That's only 50% of the cases. And so you're not going to detect it. It's not like cystic fibrosis, in which it's an easy target. And so that's the problem, is there's such variety in mutations that it makes that test very not feasible.